women in medicine, but it was a really got it. That was a really great night and a great introduction to orthopedics. But for those that weren't on it, I wanted to just introduce myself, introduce the leadership, just so you know who we were. And this interest group really has taken off in the last 2 years. I've been really fortunate to be a part of it. And there's a lot of stuff that's going on, but basically we came up with a mission statement and values just so you know what you're getting yourself into and what the purpose of this organization is, why we exist here. And basically we want to expose people to their specialties early on in their training before the 3rd or even the 4th year. And then to get some experience by interacting both with senior medical students that are interested, some residents, and some faculty members. So we have kind of 4 aims here, and that's to provide exposure to the orthopedic subspecialty and talk about different career opportunities, to create opportunities for hands-on learning, to foster an environment of inclusivity at Robert Wood Johnson, and to establish the longitudinal mentorship relationships, which hopefully go not only through your medical school years, your residency years, but when you become an attending as well. And we're going to do this, and there's a whole lot of different things that we're going to do over the course of the year and over hopefully the course of your medical school career, if you want to stick with us. And there's going to be lectures and panels. There are hands-on workshops, shadowing opportunities in both the clinic and the operating room. We have some social events, including a tailgate planned for next month. And our hope is to build the connections both amongst the medical students and the residents. And the 3 values we chose most important being education, inclusivity, and mentorship. So the leadership, Al, Jalika, Julia, and Aman are the leaders right now, and they serve a 1-year term starting in January, ending at the end of the calendar year, when we're going to ask for probably 4 of you to step up and to take their place. And it is a lot of work, and you'll talk more to them about it, but I think it can be a very rewarding experience. And then your faculty mentors, Dr. Gatt, who is the chairman of the department, and he also is the residency program director. He has a lecture scheduled for tomorrow night in person, which I suggest you try to make every attempt to attend, but we'll also try to record that if possible. Dr. Tom McPartlin, who's been instrumental in the medical student portion of our program for probably at least 15 years. Dr. Steve Adelson, another pediatric orthopedist who's getting it more involved, and myself, who's been here for about 2 years. So going into just some different things that happen, the lectures and the symposia, we're going to try to do about 6 to 8 of those during the year. The fracture conference grand rounds, the residents do the fracture conference at 7:30 on Mondays, and it lasts about an hour. There is a Zoom login and password, which we'll share. Al will either put that in the notes or send it out at the conclusion. And if you do have some free time, please attend. You can listen to see what it's like to be a resident and some of the back and forth that we go through. And then grand rounds, we have a variety of different speakers that come in. We have some residents give talks, some attendings give talks. And then we also do our morbidity and mortality conference during that time. The attending resident student mentorship, that's going to start as early as the first year, where you're going to hear from 2nd year students, you're going to hear from 3rd year students. And at the end of the 4th year, we do a post residency match panel where the residents from the 4th year kind of explain how the whole process went and their thoughts about it and how it relates to being a student at Robert Wood. The community building, we have the tailgate scheduled, as I mentioned. We also did a 5K run, which was very successful, and hopefully we're going to do that again this spring. The research opportunities, we have an active spreadsheet broken up by the subspecialties within the department, and we're also coordinating a research listing of other opportunities outside of the institution, so everyone has a chance to participate in research, just if you want to see what it's about, or if you already know what you want to do and you want to get more involved. the clinic and operating room shadowing. Al did a great job of putting this together, and you'll see a handout if you haven't already for an opportunity to be part of this. The cadaver dissections, orthopedic instruments, 2 hands-on seminars that we had, which were really highly attended and really highly rated. We'll do those in the spring, give you an opportunity to sign up for that and get your hands on some of the tools and talk through some of the techniques that we use in the operating room. Last year, we ran our initial spring immersion week, which was a 1 week. We selected 4 top first-year students who were completing their first year, going into their second year. And they followed the application process. We chose 4 excellent candidates, and they spent a week with us. We've now increased that program to a 2-week program, and it's going to be right at the end of your classwork before the meat of the summer gets going. So for people that are interested, we encourage you to apply. Hopefully we can increase that from 4 to 6 students this year to give everybody an opportunity to spend a little more time with the faculty and residents. And then alumni engagement, we're really trying to utilize our connections throughout the entire country of bringing back some of the alumni to give talks or to come in person and share their wisdom, and also help us out as we look to have you guys go out into residency all over the place. So that's just a little bit about us. I want to introduce Jason. Jason's the 2nd-year resident. He's an absolute superstar. We've worked together, and we've worked on some research projects. He's a great writer. He's a great thinker. We spent last Friday together in the operating room and had a lot of fun working through some upper extremity cases. So without further ado, I want to turn it over to him, and he's going to give you guys a great talk tonight.
Thanks, Dr. Cott. Hey guys, my name is Jason. Like Dr. Cott said, I'm a 2nd-year resident here. I also went to Robert Wood for medical school as well. So I think this is, pretty applicable to you guys, since I know what it was like not too long ago. I was in your shoes. I'm a junior resident. I still have a long way to go, a lot to learn. So thank you for coming and, being willing to listen to what I have to say. Dr. Cott has been super instrumental in creating this liaison between the residency program and the medical school. We didn't have quite as systematized connection when I was a medical student. It was much harder to get involved with the program and much harder to get exposed to orthopedics. So this is a really great opportunity. I like watching it grow and turn into something cool where we can actually get to know you guys. And so thanks for coming. So from my understanding, it seems like most of you guys are 1st and 2nd years, maybe some 3rd and 4th years as well. Okay, so that's really great to see. So, when I was asked to kind of give this talk, people were saying they wanted to hear a little bit about, my journey and my story. And I guess we could just kind of kick it off with like a little informal, anecdote, and then I'm sure you guys can, relate to it yourself. So I was fortunate enough to get introduced to orthopedics pretty early, before medical school. I used to engage in a lot of mission trips. So I went to like Honduras and Paraguay, Dominican Republic, and even Africa. And on those trips, I had met an orthopedic surgeon who, I remember the first case I ever saw was a hip nail. And I just remember thinking like, wow, this is, pretty crazy to think about. You're hammering a titanium rod down somebody's femur and they can walk on it the next day. Like, just conceptually, that kind of blew my mind. And I just felt like I needed to learn more about it. So it's great that you guys are getting this exposure early on. So the other thing I like about orthopedics is that it's super relatable to people. Everybody, I think, in this call can talk about something that they've had an experience with some orthopedic injury, whether it be an ankle sprain, whether it be a family member that has some condition, whether it has an injury that, interrupted their sports career or something like or the other. So, my own personal story was before medical school, I actually used to be a professional hip hop dancer, very different. I just had an interest in it. I moved to California and wanted to pursue something that I found interesting. And while I was out there, I used to do stunts. I used to do like backflips and wall flips. And I actually fractured my spine. I got a compression fracture in my T11 vertebrae. And I just remember thinking like, wow, like I didn't need surgery or anything, but just the impact that that injury had on me, halted all these, aspirations that I had, and having someone to talk to and to kind of guide me through that process was huge. And I think that, that was a big part of why I ended up going into orthopedics. And, I hope many of you guys have similar experiences. Not that I want you guys breaking your backs, but I hope that you guys find that it's nice to know that people out there can use their knowledge and their hands to care and to help you out and other people out. So, yeah. All right. So I guess before we start, does anyone have any burning questions just in general? For me, this is like a super informal situation, just about residency, just about medical school even.
Hey, Jason, I do have a question.
Yeah.
I just have a question about transitioning from intern year to PGY2. Just like what differences are there, or what are things that you learned in your intern year that you think were like very valuable for your PGY2 year?
Yeah, I mean, that's a huge transition. I would say going from medical student to intern is a massive transition, because you go from not being a doctor to being a doctor. All of a sudden you walk into a room and you introduce yourself as Dr. So-and-so, and it's a big shift. You're not used to it. Patients aren't used to it. I still walk into rooms and introduce myself as Dr. Yang, and people are like, how old are you? Like, really? So it's a huge jump in responsibility. But the program that I'm at Robert Wood, as I'm sure all other programs do, they do prepare you very, very well, and you kind of see yourself grow through that process, which is tough. There's a lot of growing pains, but it's super, super rewarding when, that imposter syndrome kind of starts to fade away. And I think, as I got to the end of my intern year, I was thinking, okay, I'm feeling ready for the next step. And then you go from intern year to second year, and then it's even more of a jump. So as you go through the years, the amount of responsibility that's put on you and that's granted to you is a lot. It can be overwhelming at times, but it's also a privilege that, that's why we're here. Second year, at least at our program, we start taking junior call. You have to learn how to manage your time better. You have to learn how to, stay sharp while being the most tired you've ever been in your life. Something I'm still trying to figure out. And these are skills that, will leak into every other aspect of your life. You'll learn how to manage your time so that you can have a more, fulfilling personal life outside of work. Your relationships get better because you're talking to patients all the time now. As a medical student, you're very much just buried in studying and trying to learn the basics. Intern and junior year, second year, obviously you're still learning a lot of basics and foundation, but you're talking to patients a lot, and you're learning how to talk to patients, and you're in the clinics just, observing how attendings who've been doing this for years, how they talk to patients. And you realize even the way that you word things, even if it's the same knowledge and the same facts, the way that you word it can influence someone so much. So I would say that it's a big jump, but it's worth it.
Hi, I just had a quick question. So it seems like a lot of people, out of the people that I've talked to at least, that are interested in surgery, they seem to know what surgical specialty they want to go into. And it just it seems like the entire process is very competitive, and you kind of need to know early on where you want to go if you want to match well. Do you have any advice or guidance for people who might not be sure? Like, what's the best way to approach research, approach all of these different opportunities if you're not exactly sure what surgical specialty you want to go into?
Yeah, that's hard. I personally am the kind of person who also likes to take my time with making big decisions. So I wasn't 100% sold on orthopedics until I was actually a fourth year medical student. I had always been interested in it and had been doing research since my M1 year to keep it alive in case I did decide to go into it. but I kept an open mind throughout all of med school. I was thinking about general surgery as well. And then I was supposed to do my medical student rotation on ortho during my third year, and then COVID hit, so I couldn't do that. So it wasn't until my first rotation of fourth year that I started my ortho rotation at Robert Wood. And I remember like a few weeks into that, I was like, okay, yeah, this is what I want to do. But it took me a while. And just because I wanted to keep an open mind because I wanted to be sure. And that's okay. I think, now that step one is pass fail, times are changing a little bit. And it does kind of put more pressure on you guys to get involved and get more into research. But at the same time, it gives you more time to explore your options and spend less time, learning about histology descriptions like tram track appearance for nebulous concepts that I don't really care about anymore. But I think it's a double-edged sword. I think you should expose yourself to it as much as you can. You can have an open mind, and yeah, it's competitive, but if you really want it, it should work out. Okay. Anybody else?
Hi, I'm not sure if this is relevant for everyone, but my fourth year rotations or away rotations are also going to be. Is there anything that you did that prepared you?
Sorry, you just cut out a little bit. I don't know what's going on with your mic there, but you sound like Darth Vader. Do you want to type your question, Maria? Yeah, there you go. Yeah, there's a lot you can do to prepare, no problem. Obviously you have to read as much as you can. I really liked Netter's, and I liked Handbook of Fractures. A lot of people like Pocket Pimped. There's a lot of great resources out there. But I feel like at the end of the day, especially as a medical student, you're just expected to know anatomy. And really, it's kind of like your effort and your attitude that show the most, showing that you're able to think ahead, showing that you're paying attention to what's going on, that you can anticipate how to help people out without being annoying, without being in the way. Really, at the end of the day, if you can do those things, show that you're studying, show that you're engaged and you're curious and you're enthusiastic, I think those are really the best ways to kind of stand out. And that's really what anyone's looking for at any program. People are looking for people who they want to be in the trenches with, when it's late at night and you're stressed and everyone's stressed, and, people want to be with someone who's going to have a positive attitude and find a way to get the work done. And it's not easy, but, everyone has to try and figure out a way to do that and stay positive and stay themselves. No problem. Okay. So, I guess we can have some more questions later, but I feel like, we can get into this short lecture I prepared. It's not a long lecture, it's just a very basic introduction on just conceptually understanding like what orthopedics is about, really. So let's see. Share my screen here. All right, can everybody see that? Am I good? Everyone can see the PowerPoint?
Good on my end.
Good. Okay, cool. All right, so I feel like a lot of people, before they learn about orthopedics, they think that, orthopedic surgeons are magically fixing these bones and doing something special. But really, at the end of the day, all we're doing is using the knowledge that we have of the human body, of how it can heal. There's so much out there that we can learn in terms of the biochemistry and physics behind it. And it's cool that we can use that knowledge. And ultimately, our job is just to create an environment to facilitate that natural process that's already happening in our bodies. So we as orthopedic surgeons just have to create the optimal setting for that natural healing to take place. All right. So the last lecture I gave about a year ago was kind of talking about the basics of, how to describe a fracture, how it occurs, what it looks like. And I kind of ended that lecture by talking about a slide like this, where there's 4 principles of fracture fixation. The first step is reducing the fracture if it's displaced. You want to get it out to length, alignment, and rotation. Essentially, you want to just put it back into the anatomical position that wasn't before. And you can do that with a splint, you can do that with a cast, you can do that with skeletal traction. And that's kind of the first step. The second step, which we're going to be kind of talking about more tonight, is once you have that fracture back in the position that you want it to be in, you have to stabilize it. And that is dependent on where the fracture is, what kind of fracture it is. And there's 2 different types of stabilization. There's absolute stability and relative stability, which we'll get into tonight. Essentially, your absolute stability is promoting primary bone healing, and your relative stability is promoting secondary bone healing, which we'll get into. And then third step is making sure you have good blood supply and soft tissue coverage. I think a lot of people tend to overlook that part early on, but our friends over at plastics and vascular are very, very important to the success of our surgeries and our outcomes. And then the last step is mobilization. We want to get people up and moving and bearing weight and using their extremities as early as possible. That's safe, because you can have a perfect reduction and fixation on X-ray, but if they're stiff and they can't move and they can't do their day-to-day job, or they can't go out and do what their goals were before they got injured, you haven't really succeeded, have you? You just kind of fix the fracture. So don't forget that at the end of the day, you're trying to get function back. Okay, so those are the basic 4 principles. And to get into, I'm not going to go crazy into the weeds about the biochem and the science behind this, but essentially there's 3 phases of fracture healing. In the acute phase, you get inflammation, you have a hematoma, which brings a bunch of growth factors and fibroblasts, chondroblasts to the injury site, and they can start doing their thing. They can start promoting healing. And then the next phase after that, you get a callus formation, which is typically collagen at first, and it gets slowly replaced by cartilage. And then in the remodeling phase, you have osteoclasts and osteoblasts, which, if you haven't learned about already in medical school, they modulate the bone making and bone breaking process, and they essentially convert bone to the bone that we want. And this is just a fancy picture showing that. So early on, you have your hematoma formation, you get your soft callus, you get your hard callus, and then you get your bone remodeling. Okay, so this is something that I didn't really know about until I kind of took an AO basic course, but there's something called Wolff's Law, which essentially says that bone remodels in response to mechanical stress. And so you actually impact the ability for bones to heal and remodel based on how much motion there is and based on how much mechanical compression there is at the site. Okay. And there's two different types of bone healing. There's primary bone healing and there's secondary bone healing. And you can influence which type of healing is done based on your stabilization construct. So here it says strain less than 2%, strain 2 to 10%. That's a fancy way of saying in primary bone healing, if you have very little motion and rigid fixation, you promote the primary bone healing. Whereas with the secondary, if you have more motion, you promote the secondary bone healing. Okay, so keep that in mind. So with absolute stability, there's actually no callus formation. And you want this in a situation where you need a perfect anatomic alignment. That's particularly useful for articular fractures where there's a joint surface and there's cartilage interacting with cartilage. And you want the pieces to be perfect. Otherwise, you'll have you'll promote osteoarthritis. You'll have pain. Or, you know, an example of like in your radius and your ulna, you know, it's very important that they're aligned perfectly so that you can have pronation and supination, right? If you have, you know, a significant amount of angular deformity there, you're not going to be able to move your arm quite as well as you'd like. And the way to promote that is you need to compress the bones. So you need to find a way to get the bones to actually not only be touching each other, but you need to find a way to promote forces that push them against each other. And that promotes that type of healing. And then for the relative stability, you'll see callus formation. This type of healing doesn't require perfect anatomic alignment. You basically just have to get the bones in a position where you can bear loads through it. So for example, like in a femur, if you have a femur fracture, you don't have to have the fragments perfectly anatomically locked in together. You can use something like a titanium rod, like an intramedullary nail, and approximate the fractures together with a little bit of motion to promote secondary bone healing. You'll see callus formation there, and you actually want a little bit of motion there to promote this type of fracture healing. And this is really cool because you can bear weight on it while the bone heals, and actually bearing weight promotes the bone to heal. Okay, and this is a kind of a cool picture I found that shows this relationship. So on the left, you have a humerus fracture treated in a splint. And these actually do really well without any type of surgery, actually. And the reason that you can get away with that is that your humerus, essentially, its sole purpose is to move your arm. You don't have to have the perfect relationship between your radius and your ulna to have that nuanced motion. Okay, so with a splint, you can get pretty good stability here. And you can actually see, if you look at the fracture site of that humerus, there's a little bit of callus formation. You can see there's a little bit of bone kind of forming around that fracture site. And that's your secondary healing. And as you move to the right, all the way on the right side, you have, like I was talking about, your radius and your ulna, where you have primary healing. So that's a plate there with a screw in the middle of it, if you can see, that's compressing a fracture site. And there you have very little motion, and that promotes a very rigid construct, and that will promote absolute stability and primary healing. Okay, and this is just an example of callus formation. So I just wanted to show you, you know, at the very bottom, you can see this little hump. There's a little hump at the fracture site on the ulna there, the bone all the way on the bottom, and you can see there's like a little hump of bone there. That's callus. So you can pick that up on X-rays. You can see if a fracture is old. You can see if a fracture is acute. You can look at this and say, okay, there's some bone healing going on there. And you can see that the bone fragments are not perfectly compressed against each other. And so that's why you're getting that callus formation. And that's secondary healing. Okay, so we talked earlier about absolute stability, right? We're talking about getting compression and getting rigid fixation. And so, one concept I wanted to show you guys was how you can use a screw to promote that type of fixation. All right, so something that we use a lot is called a lag screw. It's basically taking a screw and compressing two pieces of bone together. All right, and there's two different ways to do that. There's lag by design and lag by technique. Okay, so if you look at the picture on the bottom left, you can see that there's a screw, and there's a lot of words on the screw next to it, the labeled one, but I want you to focus on the two bottom, the core diameter and the thread diameter. Okay, so when you're looking at a screw, you have the threads that wrap around it like a helix, and you have the main part in the middle that's kind of smooth. All right, there's two different diameters, and you can use that to your advantage to compress. Okay, so if you look at the top image on the right, you'll notice that the first half of it is smooth and the second half of it is threaded. So when you screw that screw into the fracture site, you want to go perpendicular to the fracture site. And as the threads engage the second fragment, it'll force the fragment to go towards the screw head. Meanwhile, the first half of the screw is smooth, and so the bone can actually slide on that. So as you're compressing here, your screw head is forcing the fragment closer to the screw head towards the fragment that's the threads are going into. Does that make sense? So that's a pretty cool concept. And then, so that's called lag by technique, lag by design, where your screw is designed to lag for you. You don't have to do any extra work. Okay. The other way is to do it the image, the way the image shows below that, where you basically take your drill and you drill two holes across the fracture site. Your hole closer to you is going to be the width of the threads, so that essentially the threads do not engage in the fragment closer to the screw head. And then in the distal fragment, the farther piece, you want to drill it so that it's the length, it's the diameter of the core diameter, so that the threads do engage into the bone as it gets screwed in. So in the further fragment, you're engaging, and in the closer fragment, you're not engaging. Does that make sense? So conceptually, it's the same thing as what we talked about earlier, where you're bringing the farther fragment closer to the near fragment, but you're doing it through a drill. And these are two different ways to do the same idea. It's just that, lagging by technique is actually a more rigid way to do it. But this is a cool concept I wanted to show you guys. And this is a way that you can get compression across a fracture site. And you can imagine how, if your screw is not going perpendicular to that fracture site, you'd be compressing it in a way where the fracture site would be kind of shearing on itself, and it wouldn't compress directly against each other. So it's important to make sure that your screws are perpendicular. Cool. So this is an example of when you'd want to be doing this kind of fixation. So in your finger, you can't really accept a lot of deformity in your phalanges. You want to have that be pretty anatomically accurate. Just a little bit of rotational deformity in your fingers can cause, not only a cosmetic problem, but you can lose a lot of grip strength. You can catch it on things. You can lose motion, flexion, extension. And so that's pretty important to get a good anatomic fixation. And so this is using interfragmentary screws here to get good compression across your fracture site. Another cool way that you can get compression is by using something called a compression plate. If you notice if you put the screw in on the right side on the top image first, right? That screw is kind of engaging into the bone. The screw on the left, as it's going in, you'll notice that the head of the plate, the hole in the plate where the screw is going in, is kind of like a funnel. It's shaped kind of like a U, like a boat. And as the screw head goes down, as you screw it in, it actually slides along that U and forces the plate to slide to the left. And so now your screw that's in your other fragment is being forced to move towards the closer fragment. And that's a dynamic compression plate. Cool. Any questions about any of that?
When you're using a compression plate, I don't know if this is just a picture, but is it still a by technique type of screw that you need to use, or can you use like the by design lag screw?
So you can use, so a lot of the times, so like these are actually like locking screws. So when you're putting the screw in distally, that's just kind of holding the bone in place. These aren't lag screws. All right, so the lag screw would be the one that's going more across the fracture site.
Great.
Okay. And you can often use those in combination. You can use your lag screw across the fracture site and then put a plate over that screw just to stabilize the fracture. That's called a neutralization plate. So you can use them in conjunction.
Jason, could you explain the difference between locking and non-locking screws, and in what instances you would want to use both of those?
Sure. So a locking screw is one where the screw has threads on the head of the screw, and the plate engages the screws of the screw head. So when you put the screw into the plate, it's screwing it into the plate. And so that screw is really just a placeholder. It's really just there to hold the place in. And it's kind of like an internal X-fix. I don't know if you guys are familiar with X-fix constructs, but you're basically, yeah, it's an internal X-fix that's right on the bone. And you want to use that for, osteoporotic bone, where, you're worried about getting, if you compress too much, you can propagate the fracture, for an example. You can use locking screws in a situation where you have a very, let's imagine you have like a very distal fracture in your ankle or your tibia, right? There's not a lot of bone where you can purchase good screws very distally, in which case, putting a few screws in that lock into the plate and just hold it in place and allow for healing, that's a good situation for that as well.
I'm just curious, do you guys ever have problems with the screws stripping, or?
Yeah, definitely. That's when you're starting on your rotations and attendings are handing you the screwdriver and you get overly excited and you're like, oh yeah, I get to do something. Something they're always going to tell you is like, don't strip it. And that can totally happen if you if you go too much and then and you strip it, then now you have a new problem where you can't really get it out if you need to get it out.
And then I have sorry.
No, go ahead.
I have a second question. You mentioned earlier that by technique is more stable than you said by design. Why is that? It seems like by technique you would have to kind of make a bigger channel on the side closest to the head, and there's less, I guess, surface area of the screw engagement with the bone, if you know what I mean. So I'm just curious.
Yeah, that's a great question, and I don't have a great answer for it. I remember that's what I was taught, that the lag by technique is more rigid. I don't really know why. I don't know if Dr. Cott has an answer if he's listening, but.
I think you signed off.
Okay, that's fine.
Yeah, thanks.
Yeah, no problem. All right, so like we were talking about earlier, we have different types of plates. You have the compression plate that we were just talking about that compresses the fragments together. We have the neutralization plate that I was talking about earlier that basically protects the stability of your fracture site. You have buttress plates, which are more used for articular pieces. So you can imagine the top of your tibia is kind of like a cone. It flanges out like this. And so if you have a fracture that you need to stabilize against gravity, the buttress plate gives you that like a perpendicular force. And then you have a bridge plate. So the concept here is that just because you use a plate doesn't mean it's absolute stability. You can use plates to do absolute stability or relative stability. You can use a bridge plate here, which essentially is like we were talking about, like the locking screws where you have it across the fracture site and you don't actually have any screws through the fracture site itself, but they're holding the fracture in place. That's if you have a really comminuted fracture, you can't get great compression. We want the bone fragments to be held in place with a bridge plate. And that's actually a type of relative stability. So we're not going to go too deep into those different types of plates right now, but I just wanted to introduce them to you guys. Okay, and this is an ankle ORAF that basically utilizes these concepts. So on the medial malleolus, you have lag screws there that are purchasing into a fracture that would be on that left side and compressing it up towards the main bone. And then on the lateral side, on the right side, you have that screw that's free. That's your lag screw. That's what's creating compression across your fracture site. And then you have a plate that's kind of supplementing that fixation. Okay. All right, so going a little bit more into relative stability, there's different types of relative stability. There's splints and casts, like we're talking about earlier, that just kind of hold the bone in place. Then you have your intramedullary nails, like we were talking about earlier. Usually with like a hip fracture, you can just put a rod through, and then you put like a distal interlocking screw to prevent it from rotating. But at the end of the day, you can bear weight on that, and that bearing weight compresses the fractures, the bone piece together through the rod. Okay, and then you have an external fixator, which uses what's called ligamentotaxis. So basically the ligaments that are already in your body, the X-fix just kind of holds the bones in place and lets the ligaments of your body hold the alignment in place. And those we use for more acute settings where you're worried about soft tissue injury and swelling, and you want to just temporize and hold things in place until you can do definitive fixation later. All right, and this is just an example of an IM nail. You can see some callus forming in that bone there. And here's an example of an X-fix. Right, so you can throw an X-fix on pretty quickly. So in specific types of fracture patterns, like ones that are very commonly treated with an X-fix early on, is called a pilon fracture. That's a fracture of the distal end of your tibia as it articulates with the talus. Those types of fractures are notoriously known to have a lot of swelling and soft tissue damage. And so if you go ahead and put a plate in there really early on, you can actually cause more trauma, right? Because surgery is essentially more trauma. So this is called damage control orthopedics, which is a whole other topic in itself. But essentially, if you have an acute injury, there's a lot of swelling that still happens, and you go in there and cause more trauma, you can cause what's called a second hit phenomenon, and basically cause an even worse inflammatory process. That's not going to promote healing. And so in that kind of situation, you want to throw on an X-fix to temporize, get it out to length, alignment, and rotation, and allow for the soft tissues to do what they need to do. Okay. Yeah. And that's it for now. That's all I have for you guys. It's just a basic introduction into different concepts and thinking about how to think about things when you see them on the floors. Asking yourself, is this like absolute stability? Is this relative stability? Why are we fixing it this way? Why are we fixing it that way? Yeah, just broad overview.
Well, that's really great. Thank you, Jason, for the talk. Definitely learned a lot and appreciate your time here. There's still 10 minutes left in the meeting, so if anyone has any questions, please don't hesitate to ask them.
How do you guys feel about everything so far? How do you guys feel like medical school is going? How do you feel like the application process is going?
Speaking from the M2 perspective, having anatomy under a belt definitely helps a lot when it comes to understanding at least some of these fracture patterns, even though we haven't seen that many. But I know in fracture conference today, when we saw some of the humeral fractures and when docs are asking, like, what does neurologically intact mean? Like, let's say if you have a humerus fracture, you have to worry about the radial nerve. Last year, probably would not have picked up on that, but then this year, I was. What's up, Coop? You got a question?
What's up, man? Yeah, thanks for speaking to us, Jason. I guess I'm just wondering, I'm kind of in a similar position, like thinking about general surgery and orthopedic surgery. And I'm just kind of wondering, like, how you made that decision to do ortho. And it's such a niche field. Like, did you ever feel like it was a difficult decision leaving so much medicine behind to learn something very specific like orthopedics?
Yeah, I mean, you feel like, going into orthopedics, you do leave a lot of medicine behind, but you really don't. There is actually still a lot of medicine involved. You're not managing like diabetes and high blood pressure and everything, but just the other day we had one of our total knee patients that we were the primary caretakers on, and she started having a hemoglobin of 4, and she was a Jehovah's Witness and couldn't get a transfusion. And she had, started having some melanotic stools, and we had to kind of figure out what was going on. And, yeah, we fixed her knee, but, there's so much else that can happen that you still have to stay abreast of, and you still have to think about, if you have a lady come in with a hip fracture, who's, 95 and has a lot of medical comorbidities, you have to think about the costs and the benefits of doing surgery. Like, yeah, you can learn the techniques of doing the surgery and the indications, but you still have to keep in mind, like, well, she has AFib and she's on blood thinners and she has these comorbidities and these are going to predispose her to these complications. And so you have to think about all that together when you're deciding what to do and how to talk to the patient and their family too. So I kind of like that I left a lot of it behind, but it's still very much with you, even within ortho.